Welcome to the 750th day of Zoom session of IFPH, International Forum for Promoting Homeopathy. Today, our guest is Dr. Arun Varghese, MD. He's the Assistant Professor, Department of Medicare, Father Mulla Homeopathy Medical College, Bangalore, Karnataka, India. The topic is common degenerative joint diseases. So, on behalf of IFPH, I am welcoming you, Dr. Arun Varghese.
Degenerative joint disease is having a common pathology wherever it may be, particularly in osteoarthritis, especially in the knee. It is considered as a joint failure. A joint fails to do its purpose. Hence, it is dysfunctional joint. Okay. So as you can see here, note here, the most commonly affected ones are our axial skeleton or our weight-bearing joints. Other weight, the in OA, we see other non-weight-bearing joints are also being affected. Like for example, finger joints are also affected. Other than that, most of the joints are weight-bearing. But if you take from above downwards, your cervical spine, lumbar spine, hip, knee joint, and your first metatarsal, not tarsophalangeal joint. That's your ball of your great toe. All of these are weight bearing. Your weight directly comes to them. And like we described this earlier, and it's a most common condition. As in arthritis, it affects almost all the, like Sir had described, but it's most commonly occurs once you age above 40. It's not necessary that all the persons above 40 should develop uh, osteoarthritis, any joints. And so there are multiple factors which can cause or precipitate our joint affections. So these are like we had discussed earlier. These are the like we can see here. Other than fingers, all the other joints are weight bearing. First, carpometacarpal, distal and proximal interphalangeal joints, that are two finger joints. You might have seen in that we'll see later, and you might have come across many of these conditions. So what's the primary pathology, or what happens, or how it occurs? So you can see these are cartilages, right? Primarily the loss of cartilages, that's the central pathology for any osteoarthritis. I'm not even only talking about knee, but we can include our cervical or lumbar spinal complex, cervical and lumbar spondylosis, both of them also. Okay. Now, what are the evidence we can see in case of if a person loses cartilage? That all of you are familiar with the finding of X-ray. Compared to a normal knee, the joint space will be reduced. Joint space is not an empty space, like it's cartilage is radiolucent. That's X-ray passes through them, so it will not be visible in X-ray. But the visible ones are bones. The visible reduction of distance between the joint space indicate that there is a loss of cartilage. Then comes our second part of it, osteophyte. These are excess bone growths. Okay, excess bone growths that we can structuralize this, or we can put a correct category or criteria to define them. that we'll see later. Okay, and first and foremost, we must have to diagnose or to say this is having an OA. You should have loss of articular cartilage. So this is normally. So compared to this, we'll see next both two X-rays. So this is an intermediate case of OA. So here we can see the compared to first one, joint space is slightly reduced, and so it's the loss of remember this, okay? Loss of cartilage on the joint. It's never a uniform one. Mm, we'll see as we see other joint deformities also. So here, so there are compartments in the knee, right? You are familiar with that. We have a medial compartment, and this is a lateral compartment. So in some cases, here you can see the medial compartment joint space is reduced, whereas in case of lateral, it's not much. So it doesn't mean that this side is normal. Of course, some pathology is going on. You can see in the edges, okay, edges here. So you can see the excess bone growth on the both side particularly, and here it's evident both sides pathologies are there. And next comes the next part. This is an advanced case of OA. Here you will not see compared to the previous one. There is no articular cartilage. It's completely gone. And addition to that, you can see the knee is deformed as plus, right? It's bent. It's bent sideways. We call genu varum or bow legs. It's further. Then once it's developed further, it translates into uh, knee becomes more dysfunctional. More dysfunctional. It creates further damage. I hope it's clear. We can just go through the three images. This is normal. Slightly changes starting to happen. This is advanced case. And this there are various stages to classify. So we all do as practitioners. We all instinctively do this. We classify if it's severe or this is just a whatever you're doing. This just structurizes it. This just structuralizes what you are doing. You are doing instinctively. So this is based on the deformities present or changes in the X-ray present. We classify the X-ray into four categories. One doubtful, minimal, moderate, and severe grade. So what are these are based on central pathology of osteoarthritis, knee osteoarthritis in particular. First change is like we have seen earlier. First change we are going to see joint space narrowing. Doubtful. We are not sure if it's present or not. Comes in the second one. You are seeing a possible narrowing, and third one definite. The moderate is definite joint space narrowing, and last one there is marked like we have seen earlier. The joint space is completely osteophytes, or we call it lipping because it looks like projection in the joint space in the articular area. So here possible one and possible definite osteophytes, and moderate we have multiple osteophytes, and severe ones we are going to find a large osteophyte. Okay, this is our classification for Kellgren-Lawrence system of classification of osteoarthritis. This is not the contents of it are not new to you, but only this grade will it gives a structure to our to us, and and this based on this only we had classified here joint space narrowing and margin osteophytes subchondral just below the articular cartilage or articulation. We are going to find a thickened line. We can go back to our old X-ray and try to see that. So compared to our older ones, you can see there is newborn formation along the joint margin, along the joint. This is sclerosis, a newborn formation, and the subchondral cyst. Okay. Now this is our non-weight bearing joint uh, fingers. This you might have seen as a person becomes older, it becomes extremely common. It doesn't mean that he has to develop a complaint. It rarely produces pain and rarely creates complaints for the patient. Like we have seen earlier, 10% of only 10% of them with hand OA only will suffer from pain and functional reduction. Okay. So this osteophytes nothing much. So here you can see the osteophytes on the joint margin. Slight the projections which come out. Sometimes inside the joint you can see the uh, this if it breaks and comes inside the joint space, that also you can see. And I'd like to add few examination points to this. And as far as your examination is concerned, you may not find acute inflammatory signs like redness, tenderness, is especially on the joint margins you can find. Other than that, redness and large swelling. It indicates something else. If it's present with fever, it's something else. And as we are checking for um, the fluid inside our capsule or a joint space, we are going to we all familiar with that. We are going to check, is there any fluid inside the joint, and if fluid is there, of course, excess fluid, we are going to check. What we are going to do, we are going to ask them to lie down and tap the patella. You're familiar with that patellar tap test, and this patellar tap test positive indicates what we are going to feel is the patella bounces, strikes the tibia and bounces back. If there is normal amount of fluid, you will not see this, or you will not feel it in your fingertips. If you're feeling this, definitely there is excess fluid inside the joint. Uh, and we have to actively measure the range of movement and movement restrictions, because OA is long-standing disease. The functions which are lost and the movement functions gained will not be perceived by the patient. So it has to be written in a non, what to say, you have to convert it into numbers, or descriptive manner. Other things you go patient will not perceive it. Minor gain of strength, minor gain of range of movement, patient will not sense it. It needs to be uh, structurally written. So we we go to the uh, oh, one second, one second, 1 second, doctor. Please excuse. These are the uh, joint space. It's always on the pressure. The weight is distributed equally on the joint space available, or the weight is supposed to be distributed equally. And normally it's not supposed to develop osteoarthritis. Like we have mentioned earlier, a person to develop osteoarthritis, the knee has to have something pathologically abnormal, physiologically or pathologically abnormal structure has to be. So what all fails to distribute the weight or spread the weight of our body in the knee or any joint space provider, joint space, joint capsule and ligaments, muscle. This is most important ones are these two, muscle and sensory afferents. Muscle we are familiar with. No, yeah. One could argue that even a sportsman can develop osteoarthritis. Yes, that's definitely right. That's due to overusage. What we are talking about is optimum muscle strength. A person must have optimum muscle strength to distribute the weight through the joint. Otherwise, what happens? You may experience this uh, after prolonged bed rest. We all might have experienced back pain, or the muscle is not strong enough to uh, distribute the weight or catch the weight. This is without muscle strength, OA will only progress. So, in order to this okay. In order to have a better prognosis at osteoarthritis or any degenerative disease, muscle strength is mandatory. Without proper rest, muscle strength, knee or any joint will only get weaker. Second comes most of your or you going to note down or you're going to note in case of diabetes mellitus. Diabetes mellitus, as a person develops peripheral neuropathy. This is one of the risk for it. And why do or we- from others' perspective, why do people suffer from osteoarthritis? So there are susceptibilities, even genetic. Okay, what are these susceptibilities? So we can prevent it. First one, some we can prevent, some we cannot. First one is previous damage, accidents, muscle weakness from any cause, joint malalignment, and proprioceptive deficiencies. Like we have seen sensory efferents complaints with that. And systemic deficiencies, by no means I say that female is deficient, but female sex is more vulnerable to develop. This is what's the meaning of this. Female sex is more vulnerable for OA. And second one, we cannot stop. Nobody can stop aging progress. And the third one is not in our hand. Uh, Genetic susceptibility. If you're and if uh, we have family members suffering from it, we tend to develop. uh, and nutrition status. Last comes the third part of susceptibility, that is increased load. Increased load, particularly two extremes of it. One is overuse in case of athletes or anybody. Those who manual laborers, farmers, they are more susceptible for it. Miners. Then comes to your another part of it is uh, another overeating or obesity is another increase load. Is about genetic vulnerabilities. Hand hip boy. 50% of cases. That means family history was nobody considers this as genetic disease, but genetics is attributable, or we have mentioned earlier mathematic predispositions. That also we can consider. It's if members had all these complaints, the families, we have more tendency to develop. There is an exception to it, our knee osteoarthritis. It's mostly comes from injuries than hereditary. It's more like a injury predisposed to. Uh, comes so these are abnormal abnormal knees. No, not abnormal. These they tend to develop, or this causes abnormal loading, right? So you'll be able to guess which part of uh, uh, is it medial compartment or lateral compartment. In the first one is normal. Second one you'll be able to guess, is it on the medial compartment or on the lateral compartment. A person develops OA. So you can assume which side the weight is being put. Uh, any guess? Okay. So it's on the medial side. You can see here, right? The weight, if you put a direct line here, the weight will. This is laterally spared, but medial you will get OA, or this cartilage will go first. This again another, and here you can guess if this side is it the medial compartment or lateral compartment. Uh, you will be able to guess. So it's on the lateral side here. So here you see medial compartment is not fully spared. It's rare compared to lateral one. Spared. Spared means he develops the loss of cartilage on the lateral side first. Spectrum. In the early stages, the knee pain is activity related. It's better with the rest, and as the person exerts, it becomes worse. Whereas in case of your severely progressive OA, we are going to get night pain, nocturnal pains, it's a syphilitic, it progressive, more destruction, syphilitic side it goes. So here, when you're comparing with the other causes, particularly inflammatory arthritis, we find brief morning stiffness. That means within 20 minutes, the knee will be stiffness will be gone. With more than 30, 20 minutes, there you're going to suspect inflammatory arthritis. Okay, inflammatory means uh, not OA. Okay. So Clinical features of lumbar and cervical spondylosis you are familiar with. Hand we had discussed already. Hand rarely produces symptom. The hip is we see the hip later. Now coming to cervical, you are familiar with that. The cervical need not present with the pain first. It may present with the vertigo first. Sometimes it presents with vertigo, and the pain usually cervical radius downwards. You are going to suspect radiculopathy, right? The pain radius downwards associated with vertigo. So here you examination, the movements will be restricted. So what are movements we can ask the patient to try out. So you're going to ask the patient to touch the chin to the his chest and touch the ear to the shoulders. These are movements you can ask the patient to imitate. If it's not possible, you can suspect it. Mostly you're going to find paravertebral stiffness. That means the muscles will be stiffened around the area affected. This you mostly will find during the palpation. And coming to a lumbar spondylosis, most common affected one is L4 and L5, and it need not present with radiating pain like sciatica. It rarely happens, but if lipping and osteophytes is prominent, you may find radiating pains. Okay. Now, hip OA. Coming to our hip OA, our last point. Last point, internal rotation. Passive internal rotation will be lost or deficiency. You're aware of when you try to rotate the feet to the feet medially, not actively, passively, that will be lost. Mm. And other diagnoses are there. Bursitis usually presents can like OA. It also comes from minor prolonged injuries. Bursitis usually have a large swelling. In case of acute one, you will find redness and tenderness, all the features of inflammation. Whereas in case of your chronic bursitis, you may not find any inflammatory signs, just the swelling you will find. The people predisposed are those who are constantly in a kneeling down position. My, Kneeling down position. Those who wipe the floor, those who pray a lot. Okay, the micro injuries it causes. That's it. This is our last slide. This was one of the study which was conducted by our senior. So what madam had found was Restox. It alters, not only helps this, especially in Restox cases only. Okay, the cases Restox were indicated and given. These cases were found not only in the symptomatic level, but also serum hyaluronic acid level also was changed. This is the toxicodendron pubens is nothing but Restox. It's a scientific name. It was the change was also seen in serum. With this, I'd like to conclude our session.